Imagine a patient's heart is just starving for oxygen. They're in agonizing, crushing pain.
Yeah, and human instinct says hit them with the strongest painkiller you have.
Right, but if you look at the instruction manual for the human body, the very first thing you give them isn't morphine. It's a basic, everyday aspirin. Welcome to the deep dive.
We are looking at a very specific, like a very high-stakes set of notes today.
Yeah, you shared your pharmacology study notes for your massive final exam coming up on March 22nd, 2026. And, looking through these, it's clear this isn't just some list of vocabulary words.
No, not at all. You are literally learning how to manually override the body's hydraulics, its electrical wiring, and its neurological systems just to save lives.
Exactly. And since you are prepping for this final, well, we are here to make sure you crush it. Like, we aren't going to just read your flashcards back to you. We're going to connect the dots.
Right. We want you to understand the physiological why behind every single one of these medications so you never forget them.
Okay, let's unpack this. We're going to start with the body's fundamental plumbing system, the pressure cooker. Like, how do we control the actual pressure in the pipes?
Well, to understand the plumbing, you have to look at the master equation for blood pressure. Blood pressure is your cardiac output multiplied by your peripheral resistance.
Okay.
So cardiac output is the volume of blood the pump is pushing, and peripheral resistance is just how tight or wide the pipes are.
Right, so if you physically clamp down and constrict those blood vessels, the pressure spikes. It's like putting your thumb over the end of a garden hose.
Exactly.
And the most aggressive way the body does this naturally is through the RAAS system, the renin-angiotensin-aldosterone system.
Yeah, the body's internal panic button. It activates when it senses low blood pressure, low blood volume, or poor perfusion to the kidneys.
Because the body assumes it's bleeding out, right?
Right.
They're severely dehydrated.
Right, so it furiously clamps down on the vessels and hoards water and sodium to keep the pressure from crashing entirely.
Which brings us to ACE inhibitors, with lisinopril as your classic example here. We use this drug to essentially cut the wire to that panic button. The vessels relax, the pressure drops.
But your notes highlight two major side effects, and we really need to understand the mechanism behind them. First, there's that persistent, dry cough.
Yeah, and that cough isn't an allergy, is it? It's a mechanical backup.
Exactly. The ACE enzyme doesn't just convert angiotensin to raise blood pressure. Its secondary job is actually to break down a peptide called bradykinin in the lungs.
Oh, wow.
Yeah, so when you inhibit the ACE enzyme, you stop that whole breakdown process. Bradykinin builds up, it irritates the lung tissue, and triggers this relentless dry cough.
The second major issue with ACE inhibitors is that they increase potassium levels. Now, normal potassium is an incredibly tight window, like 3.5 to 5. Even a slight bump is a huge red flag. How is a blood pressure medication causing hypokalemia?
Well, it comes back to the RAAS system. The A at the end stands for aldosterone. Aldosterone normally tells the kidneys to dump potassium into the urine. By blocking the entire system with an ACE inhibitor, you also block aldosterone.
So the kidneys just stop excreting potassium and start hoarding it instead.
Exactly, leaving the patient at risk for really dangerous dysrhythmias.
Right. And speaking of risks, your notes place a massive warning here that ACE inhibitors are absolutely not safe for pregnancy.
No, definitely not.
If you have a pregnant patient who needs blood pressure management, you bypass the ACE inhibitor entirely and use methyldopa.
Right. Now, if cutting the wire to the RAAS system isn't the route we want to take, we can always attack the other side of that blood pressure equation, the volume.
The drain pipe.
Yeah.
Diuretics. So if blood pressure is the water pressure, diuretics force the kidneys to just drain the water out.
Yeah. You diuresis, the fluid volume drops, and the pressure on the walls of the pipes goes down.
But you are losing water and electrolytes. You are flushing out that potassium again, just in the opposite direction.
Right, sending potassium plummeting below 3.5, which, again, triggers severe electrical misfiring in the heart.
So we've blocked the panic button and we've drained the fluid. But what if the pipes themselves are just too rigid?
Well, your notes list alpha blockers as a way to drop blood pressure by relaxing the muscle walls of the vessels themselves.
But if you rapidly loosen the pipes, gravity is just going to take over. Like if that patient stands up, the blood is just going to pool in their legs.
Yeah, that's orthostatic hypotension. The vessels are too relaxed to quickly constrict and push the blood back up to the brain against gravity.
So the patient gets dizzy, their vision goes black, and they collapse.
Exactly, which is why patient teaching for alpha blockers must include rigid fall precautions. They have to sit on the edge of the bed and dangle their legs, let their vascular system adjust before they even try to stand.
Then we have direct vasodilators. These forcefully widen the pipes, dropping the pressure. But wait, if direct vasodilators open the pipes and make things easier, why does the heart speed up and cause reflex tachycardia?
Oh, that's a great question. It's basically a battle with the baroreceptors. Those are the pressure sensors in the aortic arch and carotid arteries.
Okay.
When a direct vasodilator rips the pipes open, the blood pressure plummets rapidly. The baroreceptors detect this sudden free fall and send an emergency signal straight to the brain.
So the brain panics.
Yeah, it misinterprets the drug's effect as a catastrophic failure, assuming the pump is just dying. So it screams at the heart to beat faster and work harder to compensate.
And that's reflex tachycardia. The body is literally fighting the medication actively.
Exactly. So the clinical solution here, the real exam answer, is anticipating that fight.
Yeah.
You prevent reflex tachycardia by pairing the direct vasodilator with a beta blocker.
Oh, I see. The vasodilator opens the pipes, and the beta blocker essentially puts a hand on the heart, blocking that panic signal from the brain, keeping the pace steady.
You got it. Which perfectly transitions us from the plumbing to the pump itself.
Oh.
When the heart starts struggling, we move into angina, myocardial infarctions, and cardiac pharmacology.
Angina is a fundamental supply and demand problem, right? Like the heart muscle is screaming for more oxygen than the blood is supplying.
Right. And your notes break down exactly what drives up that demand: heart rate, contractility, and wall tension.
So if the pump is beating faster, squeezing harder, or fighting high pressure against its own walls, it just burns through oxygen.
Yeah. And the primary clinical intervention for that chest pain is nitroglycerin.
Nitro reduces preload. It aggressively dilates the veins, meaning less blood returns to the heart at once.
Exactly. The heart has less fluid to push forward, which immediately decreases its workload and its oxygen demand.
But because it's such a potent vasodilator, the side effects are severe hypotension and a massive headache.
Right, and that headache is a direct result of the mechanism. Nitroglycerin doesn't just dilate the veins near the heart, it actually causes rapid vasodilation up in the cerebral blood vessels.
Oh, wow. So the sudden expansion of vessels inside the skull causes that intense throbbing pain.
Yes, and because of that severe drop in overall blood pressure, the absolute golden rule of administration is checking the patient's blood pressure before giving nitro.
Right, you cannot give a medication that tanks pressure to a patient who is already hypotensive.
Exactly. Now, to manage the heart rate side of the oxygen demand, we rely on beta blockers and calcium channel blockers. Normal heart rate is 60 to 100 beats per minute.
And beta blockers block the sympathetic nervous system from stimulating the heart, forcing it to slow down. So you must hold the medication if the heart rate drops below 60.
Right. And calcium channel blockers, or CCBs, achieve that same slowed rate, but by restricting the influx of calcium ions into the heart muscle cells, which physically slows down the contraction phase.
Which brings us back to that terrifying scenario we opened with, the ultimate crisis of the pump, an MI, a myocardial infarction.
Yeah, time is muscle. Every single passing minute without oxygen means irreversible necrosis of the cardiac tissue.
The absolute priority is reperfusion.
Yeah.
Right. Physically opening the vessel back up in the cath lab with a PCI stent or dissolving the blockage with alteplase.
Exactly.
But before the patient reaches the cath lab, you are pushing medications. This is where we look at aspirin, nitroglycerin, and morphine. Going back to our hook. A patient is screaming in pain. The instinct is painkillers. So wait for a heart attack, most people think of intense pain and reach for painkillers, but your notes say aspirin is the very first drug to give. Why prioritize that over morphine?
Well, what's fascinating here is that the crushing pain is merely a symptom of physical obstruction, a rapidly aggregating blood clot choking off the coronary artery.
Yeah.
Aspirin is an antiplatelet. It prevents the platelets from adhering to each other. Now, it doesn't break down the clot that's already there, but it halts the crisis.
It stops the clot from expanding and cutting off whatever remaining sliver of blood flow there is. It preserves the surviving muscle.
Exactly. Morphine, on the other hand, is just managing the workload.
Yeah.
It drops the heart rate, decreases the anxiety, and provides some minor vasodilation, but it isn't fighting the root cause of the obstruction at all.
Wow. Okay. Aspirin stops the avalanche.
Yeah. Once a patient survives an MI, or if their heart is chronically failing and beating out of rhythm, the pharmacological strategy shifts. We need tools to fine-tune the electrical wiring and the physical force of the pump.
Enter digoxin. This drug is fascinating because it does two things at once. It strengthens the contractility, the force of the squeeze, while actively slowing the heart rate down.
Right.
It's like a crew coach on a rowboat, right? Screaming at the rowers to row much slower.
But to pull the oars twice as hard, yeah, fewer strokes, but vastly more efficient, powerful strokes.
Yeah.
It increases cardiac output without increasing oxygen demand.
But because it alters the actual force of the heart, the safety margins are razor thin. You must listen to the apical pulse with a stethoscope for a full minute before administering digoxin.
Yes, and if it's less than 60, you hold the dose and notify the provider immediately.
And digoxin is notoriously finicky. Like, it interacts with verapamil and clonidine, which cause digoxin levels to spike in the bloodstream. But the interaction that will absolutely be the subject of a test question is its relationship with potassium.
Yeah, if we connect this to the bigger picture, if we look back at section 1, we talked about diuretics draining fluid and flushing out potassium.
Right, hypokalemia, low potassium.
Potassium normally binds to the same sites on the heart muscle pump as digoxin. So if a patient is on a diuretic that lowers potassium and they're also taking digoxin, we have just set the perfect trap for digoxin toxicity.
Because if potassium levels drop, all those binding sites suddenly open up, digoxin floods in, binding everywhere at once.
Exactly. It's a ticking time bomb.
The classic clinical signs of that toxicity are nausea, vomiting, and visual disturbances, specifically seeing yellow-green halos around light. So if you see yellow-green halos in a patient scenario on March 22nd, it is a digoxin toxicity question.
Spot on. Now, what happens when the electrical rhythm itself becomes chaotic? We use antidysrhythmics. Class 2 encompasses your beta blockers, and Class 4 covers calcium channel blockers.
Your notes pose a great true or false question here. True or false? Antidysrhythmics can actually cause dysrhythmias. The answer is true, which feels like a cruel pharmacological irony. You take a drug to fix your rhythm, and it triggers a lethal one.
Yeah. Specifically, they risk causing QT prolongation. The QT interval is the heart's electrical reset phase. These drugs can stretch that reset period out way too long.
And if a new heartbeat fires while the heart is still vulnerable and resetting?
It throws the entire electrical system into absolute chaos, leading to a lethal ventricular rhythm called torsades de pointe.
Oh, man. Well, we've addressed the pipes, the pump, and the wiring, but none of that matters if the actual cargo floating inside the blood is defective.
Right, the lipids, the red blood cells, and the severe electrolyte imbalances. This section of your notes is dense, so let's break down the mechanics here.
Starting with the lipids. Statins are the frontline defense for lowering LDL cholesterol. They inhibit the enzyme in the liver responsible for producing cholesterol, but the liver takes the brunt of the damage.
Yeah, hepatotoxicity. The most important lab value to monitor when a patient starts a statin is their liver enzymes, their LFTs.
But while liver failure is the clinical danger, the reason patients actually stop taking their statins is myopathy, severe muscle damage.
Right, it presents as unexplained, deep muscle pain, usually in the legs. That is the #1 reason patients stop taking it. In severe cases, the muscle fibers break down entirely, a condition called rhabdomyolysis, which basically clogs the kidneys with muscle protein.
Wow. If statins aren't an option, we use bile acid sequestrants like cholestyramine. The mechanism here is incredibly clever. It binds to bile acids in your gut and flushes them out in your stool.
And because those bile acids are gone, the liver is forced to manufacture more.
And the raw material the liver uses to build bile acids, cholesterol from the bloodstream. It literally tricks the body into consuming its own dangerous cholesterol supply.
Exactly. For high triglycerides, we look to fibrates. But there is a massive contraindication here. If you mix a fibrate with warfarin, a blood thinner, you severely increase the risk of hemorrhage.
Because both drugs aggressively fight to bind to the same proteins in the blood, right?
Yeah, and the fibrate usually wins, leaving a massive amount of free, unbound warfarin floating in the bloodstream, skyrocketing the patient's bleeding risk.
And moving from the fats to the oxygen carriers themselves. Anemia. If a patient simply lacks the building blocks, like iron deficiency anemia, you provide oral or parenteral iron.
But patient teaching must include warning them about black tarry stools, which is just the unabsorbed iron oxidizing in the GI tract, along with severe constipation.
Right. But hemolytic anemia, or anemia secondary to chronic kidney disease, is a different mechanical failure. The bone marrow isn't missing iron, it's missing the hormonal signal from the kidneys telling it to manufacture red blood cells.
Exactly. That's when we give ipoetin alpha. It replaces that signal, stimulating the bone marrow to pump out new red blood cells. It cures the anemia.
Hold on, apoetin alpha cures anemia by making red blood cells, which sounds great, But you're saying if we do it too well and HTB goes over 11, we create a totally new life-threatening problem.
Yes, it's a problem of physics, really. Viscosity. Red blood cells are solid matter floating in plasma. If you stimulate the production of too many red blood cells, the blood becomes sludge.
It turns from water into syrup.
Exactly. And pushing syrup through the vascular system causes massive clots, leading directly to strokes and myocardial infarctions. You have to monitor that HGB level constantly, and epoetin alpha is strictly contraindicated in patients who already have high blood pressure.
Let's talk about folic acid and B12. Your notes state that folic acid can actually mask a B12 deficiency. How does a vitamin hide a totally separate deficiency?
Well, a B12 deficiency causes two distinct problems. It stops red blood cells from dividing properly, causing anemia, and it causes irreversible degeneration of the nervous system.
Right.
If you give folic acid, it steps in and fixes the anemia portion. The blood cells start dividing normally again.
But folic acid does absolutely nothing to protect the nerves.
Right. The blood test will look perfectly healthy, effectively masking the fact that the patient's spinal cord and nervous system are quietly degrading. You must test for both.
Which brings us to the severe electrolyte imbalances. We know hyperkalemia, dangerously high potassium, affects the heart most and can stop it cold. To physically remove that potassium from the body, you administer K-exolate.
Yeah, Kieselate works through ion exchange in the gut. It sits in the intestines, trades a sodium ion for a potassium ion, and then the patient excretes the bound potassium in their stool. But that process takes hours.
And the heart doesn't have hours, so while you're waiting for the Kieselate to work, you push calcium gluconate.
Right, and the calcium gluconate doesn't lower the potassium at all. It acts as a chemical shield, protecting the heart by raising the threshold of the heart muscle cells so the toxic potassium can't trigger a lethal rhythm before it's cleared out.
On the opposite end of the spectrum, we have hyponatremia, dangerously low sodium. The treatment is IV normal saline. But there's a bolded warning: it must be infused slowly.
Yes, if you correct low sodium too quickly, you trigger osmotic demyelination syndrome. Fluid dynamics dictate that water follows salt.
So if the blood suddenly becomes highly salty from a rapid 5V infusion, water will aggressively rush out of the brain cells and into the bloodstream to balance it out.
Exactly, causing the brain tissue to rapidly shrink and demyelinate, which causes permanent brain damage.
Wow. Which perfectly sets up our final domain, the central nervous system, pain management, and neurology.
Let's start with opioids, specifically morphine. The pain relief is unparalleled, but the biggest danger is respiratory depression. The drug suppresses the brainstem's drive to breathe.
You must count the patient's respirations. If they are breathing fewer than 12 times a minute, you hold the opioid. Also, opioids cause severe constipation, right?
Yeah, always pair them with a prophylactic bowel regimen, and if they slip into an overdose, the antidote is naloxone.
Here's where it gets really interesting. Naloxone works incredibly fast. How exactly is it violently ripping someone out of an opioid overdose?
It's all about receptor competition at the blood-brain barrier. Imagine the brain's opioid receptors are a nightclub, and the opioid molecules are the guests inside, turning off the lights and shutting down the respiratory drive.
Okay, I can picture that.
Naloxone has a vastly higher affinity for those receptors. It acts like a giant, aggressive bouncer. It storms into the club, physically kicks the opioids off the receptors, and takes their place.
Wow. Because it binds so tightly, the opioids are locked out, instantly reversing the respiratory depression.
Exactly. Moving to anesthetics, we have nitrous oxide for mild pain relief, but then there's ketamine.
Ketamine causes hallucinations, right?
Yeah, severe emergence delirium, terrifying hallucinations, and agitation when the patient wakes up. To blunt that psychological trauma, you pre-medicate the patient with diazepam, a sedative that smooths out the wake-up process.
Finally, Parkinson's disease. The root physiological cause is low dopamine in the brain. The primary pharmacological treatment is levodopa, which actually crosses the blood-brain barrier and converts into dopamine.
Right, but it takes weeks or even months to take full effect, and a major side effect is dyskinesia, erratic, involuntary movements. But levodopa has a fatal flaw. If you administer it alone, the body's peripheral enzymes will destroy it in the bloodstream before it ever reaches the brain.
Which is why we pair it with carbidopa. Carbidopa doesn't cure Parkinson's. It doesn't even cross the blood-brain barrier. It's like a VIP bodyguard, right?
Yes, exactly.
Its only job is to safely escort the levodopa up to the brain, distracting those digestive enzymes so the levodopa doesn't get destroyed on the way.
Understanding those mechanical pairings, levodopa and carbidopa, a direct vasodilator and a beta blocker, Kieselate and calcium gluconate, That is what separates memorizing flashcards from truly mastering pharmacology.
So what does this mean for your exam on the 22nd? Let's briefly recap the holy trinity of holds for the exam. These are the vital signs that demand you stop and hold the medication.
Okay, let's hear them.
Number 1, hold beta blockers and digoxin if the apical heart rate is less than 60. Number 2, hold epoetin alpha if the hemoglobin is greater than 11. And number 3, hold opioids if respirations are less than 12. Pharmacology isn't about isolated facts, it's about the domino effect of the human body.
Today, we've seen exactly how interconnected these systems are, how flushing out water with a diuretic can crash your potassium, which in turn turns your helpful digoxin into a toxic threat.
It's wild.
It makes you wonder, as we move toward AI-driven personalized medicine, will we one day have dynamic, smart medications that adapt their own side effects in real time based on your specific electrolyte levels, rather than relying on a clinician to catch the cascade?
That is an incredible thought. But until those smart meds arrive, it's up to you to be the one catching that cascade. You have the instruction manual. You understand the hydraulics, the cargo, and the wiring. Good luck on your final exam on the 22nd. You've got this.